definitely EMS. Highway Patrol put me through EMT school, paramedic school, and I taught both at our academy in the EMS program at the BLS level, and then I oversaw that statewide program at the same time, and then I also oversaw the statewide program for the air operations, which was the advanced life support with 43 paramedics and 7 bases throughout the state. Give you a little bit of history of how I came to be in Sac County EMS. A little bit of history or background about Sacramento County, so you can sort of get an idea of how the county is made up. We have about 1.4 to 1.5 million people in the county of Sacramento, just the county, not the region, but the county, and about just under 1,000 square miles. And that includes all the way down into the South Delta, all the way down to the Antioch Bridge, up to our North County line, which is up north of the old Arco Arena, and of course from the Sacramento River all the way out to the east foothills of El Dorado and the Placerville, or the Placer-Roseville area. We currently have 15 EMS providers, and they're broken up a little bit different. We have 4 fire departments that transport all of our 911 calls, and we have 9 private ground providers who transport a 7-digit call. So a citizen in Sacramento County can either call 911, or if they have a specific ambulance company that they want them to transport, they can call that ambulance company's 7-digit number. And then we have 2 air providers. One is based at Mather Airfield, and one is based out of McCullen. And we handle about 250,000 EMS calls per year. That's both 911 and 7-digit providers. We currently have, for our population and our geographics, remember our geographics, basically, our demographic, or most of our population, they live either on the I-5 corridor from Elk Grove to the North County line, Highway 50 pretty much from the Sacramento River all the way out to Folsom, or on the 80 corridor, basically from the Sacramento River out to the Roseville-Placer County line. That's the majority of the population. We do have, residents out in the far South County and out in the Southeast County, which is really a lot of rural area. We currently have 11 receiving facilities, hospitals, acute care hospitals here in the county, and those are acute receiving facilities that are also, 8 of them are designated as primary stroke centers. We have, actually 9 of them are actually designated. We have 2 that are designated as comprehensive stroke centers. We're hoping that one of our primaries will be applying for certification as a certified comprehensive here in the near future. That's UC Davis. But our 2 comprehensive stroke centers are both north of the river. Okay? There's only 3 bridges across the American River. It's either I-5, Watt, or Howe. If you want to go way out, you have the 4th bridge out there by Folsom. So right now, the remaining stroke centers, the receiving stroke centers, the primary stroke centers, are all south of the American River. So the majority of our stroke centers are south of the river, and we have 2 that are north of the river. Most of our population lives south of the American River, is where the 90% of our metropolitan population is. So with that, we pretty much have, I think, our stroke centers all dispersed very well. Unfortunately, our 2 comprehensives are north of the river. Hopefully, one of these days, in the near future, we'll get a 3rd comprehensive, or maybe even with these new regulations, which I have been waiting for, because I've been watching them for the last 5 years, waiting for them to come into play. And now that I know that we have them within the next, hopefully, 2 weeks, my agency now has, once they become permanent and in regulations, my agency will have 6 months to get our stroke plan program to meet those regulations. I think we do. I think we meet a lot of them. It's just it's not in writing that we know of. minus our basic protocols. The stroke centers that we have designated, all of our hospitals, were all designated prior to me coming. So how they were designated, I don't know. That was never passed from my predecessor. But I know that all 9 of our 9 in-county hospitals, 2 out-county hospitals that we designate as stroke centers are all functioning to, at their top level as of right now. And to add to Dr. Garzon's answer and Dan's answer about air, from my past experience as a flight medic with the CHP, even if we were auto-dispatched, it still would take us, once we landed, 4 to 5 minutes to get the patient loaded. If the patient was already on a gurney, to get them transferred into the helicopter before we could lift off en route. If it's not an auto launch, in other words, the helicopter is not launched as soon as the call goes out, from the time they're dispatched, air providers dispatch gets the call, they contact the crew starts up the helicopter, you're looking at least 7 minutes, because they have to figure out the flight, they have to get the weather, make sure it's clear, and then they have to be able to spool up the engines, which takes a good 3 minutes. Even if they're doing a hot start, it's about a 3-minute hot start. Normal start's about 6 minutes to start up the helicopters. And then, of course, it's flight time and landing zone. So there are some times in the urban areas, it's better just to transport by ground and move through traffic the best you can, versus using air urban. Out in the rural areas, one of the items that we will look at if these regs go through for our stroke policies out in the rural areas, we may do an auto launch for some of our, for our 2 errors. If we know it's a stroke patient, if it comes in that way, we may do an auto launch type policy. I do know there are other counties that do have auto launches for their traumas, but they're more rural than we are. So if anybody doesn't have any questions on my part, or I'll let Dr. Garzon continue with how the county is sort of set up.
Thank you.
I just want to make a couple of comments about the clinical care, clinical aspects that come into play with the care for stroke patients in the pre-hospital setting. So I think one of the things to understand is that defining EMS best practices very frequently follows on the heels of first hospital-based emergency care defining what their best practices are. I mean, there's certainly primary EMS research and nuances of things that get researched primarily in the EMS setting or pre-hospital setting, but for, I think, large system care issues, stroke care, heart attack care, trauma care, a lot of that is driven by the medical literature that is really emergency and hospital based, and then EMS reacts to that. And so I think what we're going through now in the pre-hospital environment around what's the best way to take care of stroke and the regs that are coming out and those kinds of things is really following on the heels of the medical literature that's showing that patients with certain kinds of symptoms or conditions will have better outcomes if they're taken care of in certain level of care, certain specialty centers which have already been defined. And so then our reactive approach is, okay, how do we in the pre-hospital setting identify those right patients and get them to the right centers? But the medical community is already years down the path of defining what are those right centers in a way. And what we're doing now with stroke care, we did, for example, with heart attack care perhaps 15 years earlier, right, in defining PCI centers, and we did that with trauma care 40 years ago when the medical literature showed that trauma patients did better when they got care in hospitals that did a certain volume of trauma care. And then the American College of Surgeons started to come up with a criterion certified trauma hospitals, and EMS reacted to that and said, okay, how do we get certain patients to those centers? And to give examples of what we've learned from those experiences, the American College of Surgeons and other bodies get together and they review these guidelines. So there are pre-hospital guidelines to get trauma patients to trauma centers that are actually fairly complex. They follow a big algorithm There are physiologic criteria, for example, certain obvious injuries that a paramedic has been trained to know, okay, that has to go to a trauma center. And then there's a second tier of criteria that we call mechanism of injury. It's, a crash of a certain speed, a fall from a certain height, that even if the patient looks okay, it's just that the mechanism of injury was so significant that medical literature has shown that many of these people do have a significant injury that will benefit from a trauma center. So we've gone through decades of refining those guidelines that paramedics have gotten very good at using to identify who's an appropriate patient for a trauma center and not. For heart attack care, it's a little bit simpler because the big thing is to do EKGs in the field. And that actually, the evolution of specialty care for myocardial infarctions drove doing EKGs in the field. Because now, if we can take them to one center or another, we're going to have to define a way to determine what patients need that care. And the default for heart attack care is a 12-lead EKG that paramedics can transmit to a hospital and have a cardiologist look at it. Or now the algorithms to interpret those EKGs are so good and have high sensitivity that even the machine reading can tell a paramedic whether or not they meet certain criteria and should go to a heart attack center. So we're kind of seeing that with trauma care, with stroke care now, basically. So the pre-hospital stroke care in Sacramento, a quick outline that we've had actually a stroke policy, I believe since 2010, give or take a year, that actually uses the Cincinnati pre-hospital stroke scale to identify patients who may have a stroke, and they're supposed to go to one of our trauma centers, one of our stroke centers. And so we are one of those 2/3, as Dan mentioned, 2/3 of our EMS agencies in California have some type of stroke policy or system in place, and so we're one of those. When we started that policy around 2010, at the time, I think 4 of our 11 911 receiving hospitals were designated as primary stroke centers. And I think, as Chuck mentioned, this happened in Santa Clara. Once that policy came on board, the other ones kind of quickly caught up and got designated as stroke centers as well. And now what we're seeing is that the evolution of care. We've defined comprehensive versus primary. The medical literature is evolving almost month by month about what's the best care for patients with certain symptoms to get. And so I think the challenges we have right now is identifying the best stroke scale for paramedics to use in the field. As I mentioned, we use the Cincinnati Pre-Hospital Stroke Scale, which of the 2/3 of the local EMS agencies in California that have a stroke system in place, about 90% of them are using the Cincinnati Pre-Hospital Stroke Scale currently. But there are many others, and they have pros and cons. And I think one of the challenges with those is how sensitive and specific are they to identify the right patients to go to stroke centers. And then the other one is determining the best destination based on that stroke scale. So you heard the distinction between the services that are available in primary stroke centers and comprehensive, but then there are also hospitals that can do the embolectomies or do the intervention, but are not designated comprehensive yet, but theoretically would be able to provide the intervention that's necessary for the large vessel stroke. So it's all a complex system that's evolving. The EMS medical directors meet quarterly. We're constantly in review. We've seen the draft regulations that are going to come out soon, and so we're in Sacramento staying in the front edge of what's going on around stroke care. I think as far as I know, of the 31, 32 EMS agencies in the state, Los Angeles is starting a pilot to divert patients to certain patients to comprehensive centers and certain patients to primary stroke centers. And then, as mentioned, the one in Santa Clara, which is fairly new, which is actually a very novel approach. It's different than almost any other EMS agency in the country. So it'll be interesting to see what kinds of data they get from that and in Los Angeles.
Thank you. So as we take our whirlwind tour through stroke care in Sacramento County, we're going to have the panelists, I think, come up to the front. Yeah, okay. And I'm going to do a very brief introduction for them. You can read more about them in the bios that you have in your packets. For those of you who don't know me, I'm Betsy Thompson that Jose referred to earlier. I am your federal partner today with the U.S. Department of Human Services. I work in San Francisco in our regional office there. So you've heard about the challenges that are fairly substantial in Sacramento County. One success story, very appreciative for Chuck, and then what we do to get people to care. Now we're going to hear from the stroke directors about the care itself, and I don't know what else they might cover while they're up. Dr. Balmer is going to moderate the panel. Many of you know that him in his many roles that he has related to cardiology and to stroke. He's very well known, currently has a number of paths at the American College of Cardiology as well as at UC Davis's Division of Cardiovascular Medicine, where he's a professor, director of the non-invasive services, and director of the Cardiology Fellowship Training Program there. So he's going to moderate the panel. Lucian Maiden, and I'm sorry if I'm butchering your names because I didn't get to ask you beforehand how to say them, is currently the medical director of neurovascular medicine at Mercy San Juan Medical Center and at Mercy Hospital of Folsom. He's also the director of neurovascular medicine at the Mercy Neurological Institute. Quan, I'm sorry, Quan Ying?
Ing, yeah.
Ing, okay, I was close. Is director of vascular neurology at UC Davis. He's a neurologist who specializes in vascular neurology as well as neurorehabilitation and focuses on treatment and prevention of stroke as well as subsequent recovery. Richard Atkinson is the director of Sutter's Neuroscience Institute and Stroke Program and is a neurologist and as well as a director there. And last but not least is Jonathan Hartman, who is the chief neurologist at the Sacramento region for Kaiser Permanente, where he specializes in neurological surgery and is quite passionate about hypertension control and stroke prevention. I think I got them all. So they're yours.
Got it. Well, thank you very much for coming today. We really appreciate this effort. What we're trying to do is change Sacramento County from Stroke County to Survivor County. And we want to change the meaning of the S in Sacramento. We have gathered the stroke experts from Sacramento County here to discuss areas. And what I would like to do is for the panel, do you feel comfortable sitting there and talking with the microphones, or do you need to come up here?
This is fine.
Is that going to be comfortable to sit? What I'd like to do is what is tradition in Sacramento is ask you to do each 6 minutes. We're going to start with a 3-minute hot start. So you get 3 minutes to warm up the helicopter. And for 3 minutes, each of you, I want you to tell us what you're doing in Sacramento right now, your institution for taking care of stroke. And take the second 3 minutes to tell us what you anticipate doing or would like to do as we see the evolution of stroke treatment changing remarkably quickly at this point in time. If we were talking about STEMIs, we started doing primary STEMI therapy or interventions in the 1980s. So we're roughly 30 years later in getting to primary stroke interventions. But that does appear to be the direction that we're going at this point. So we see ourselves in a rapidly changing environment. That's why I'd like 3 minutes on what you're doing now, and 3 minutes as to what direction you want to go and what direction you think we want to go, and then we'll open it for questions after. So I'd like to start with Dr. Maiden, who is the stroke director at Dignity Health first.
Thank you for having me here. So I'm going to make a very important correction. We're doing
Could you
intervention.
speak up, please? Can't hear you.
Is that microphone on?
No, this is Is this good now?
There it is. Just project. Use your
Can
singing
you hear me
voice.
now?
Yes.
All right.
You're singing in the
So
shower.
I'm gonna correct you with the neurointervention. So I was a neurologist in 1998, UC Davis, and I was training with Dr. Atkinson at that time. He was the stroke director at Sutter. And we had a very interesting device called Mercy. It was like a corkscrew, very ineffective, but that's how we started in the late 90s using the Mercy device. And it's true that we trailed behind cardiology since then, but in 2010, actually in Europe, a new device came on the market called stent retriever. And there was a little known trial between 2010 2012 in Europe. It was called STAR, where they used this device on 200 patients, and the results were outstanding. This came before IMS-3, the device, the trial that said that there's no benefit in doing neurointervention. There's not going to be any improved outcome if you do that. So we have a history of training behind cardiology, is true, but we were doing neurointervention way back. Now, it's a nice setting, everybody's sharing stories. I'm going to share a personal story. I was a general neurologist, going by my business, taking care of stroke care, and then I realized that the current treatment at that time, in the 90s, in 1995, I have to remember the TPA was approved by FDA, and that was the only medication that we had. It wasn't very effective. It was a jump in what we were doing. It was outstanding, but wasn't taking care of all the patients. So I went back to training. I trained in neurointervention. It took another 4 years to do that. And I'm having this perspective of being at the whole spectrum of stroke care. I'm the neurologist, I'm the teleneurologist who diagnosed the stroke, I'm the vascular neurologist who takes care of the preventive part and then the follow-up, and I'm doing the intervention. I'm the guy who at 3 o'clock in the morning is going to go there and try to take the blood out, like my friend Dr. Hartman from Kaiser. So I have a unique perspective, and that's what I'm going to share with you. In the last 5 years, I think we have a revolution in the treatment of stroke. I think that we're going to be swept away by what's coming out, by the trials that will be published in the next few months. Chuck mentioned something about the trial. It was called Dawn. Where is Chuck?
He had to leave for
So
Santa.
the trial that Chuck was mentioning is called Dawn. And they stopped enrollment after they did an interim analysis of 200 people because it was outstanding. 73% of people had a better outcome at 90 days using this mechanical thrombectomy. A second trial that we are one of the sites, it's called Diffuse 3. The PI, the principal investigator is Dr. Albers from Stanford, I know him. It's stopping enrollment because the results are fantastic. You can treat beyond the 6 hour, that it's level 1A care now. And I think this is going to change again the landscape. So we are facing some data that we're going to have to deal with pretty quickly. So we were designated Comprehensive Stroke Center Mercy San Juan 3 years ago. We went through a recertification. What does recertification means is they look at your processes, they look at your processes, they look at what you're doing. It's very good to get certified, but then you have to prove that you're doing a good job. So every 2 years you're getting recertified as a comprehensive. There are there are two major entities that certify centers in this country. JCO is the most prestigious, and we were certified by JCO. In LA County, 2 are certified by JCO and 1 by the other agency. San Joaquin County is the 3rd county in the United States that started this diversion program. So I'm going to answer your question. Where do I want to have my stroke? God forbid, if I have a stroke, I want to have it at Mercy San Juan to be taking care of my team. Right? So come on, cheer up. So then, and why? Because we think that having a designated comprehensive stroke center is not just a marketing gimmick. You have to do not only a certain volume with certain outcomes, which are independently checked by the JCO, you have to do research. You have to be at the forefront of the research, and you have to do community education. So I think that in the next future, all my colleagues will be in the comprehensive stroke center, which we have to be. I think the stroke care nowadays, it's a community effort. We have to put down the silos that we live in. This is not going to be a condition that can be managed by one system. You're going to have volumes that no matter how many people you're going to hire, how many micro and angel suites, these are the places where we deal with these strokes, you build, you're going to be swamped by the number of patients. You're going to be swamped by concomitant stroke patients that have to be taken care of. So, anybody from Rhode Island? Why I'm asking about Rhode Island? And then knows why I'm asking about Rhode Island. Because Rhode Island is the only state that legiferated this diversion. They have 9 comprehensive stroke centers, 9 primary stroke centers, 1 comprehensive. They have 1 million population, everybody goes there. And for good reasons. So, you ask for the next 3 minutes, what do I want? I want to have a state and county level policy that deals with this large vessel occlusion patients, meaning that depending on what expert you ask, between 10%, some people venture to 40% of people will have a large clot sitting in a big vessel that can be accessed through the groin, and it's not respond very well to IETPA, the only medication that we have. So we're going to have to think how we triage in the field, how we identify these people in the field and where they go. And more important, they have to go really fast. Time is running also, and it stays the older the better.
Thank you very much, and thank you for staying on time. We will have questions when the 4 panelists have completed it. I'd like to move to Dr. Hartman, who is the stroke director for Kaiser Permanente.
Thank you. So, just one correction also. On the sheet there, unless I've done not just 1, but 2 additional residencies that I don't remember. So, I'm just a simple radiologist who was thrust into this role against my will. So looking at what we have done, the comprehensive stroke center designation obviously is a big one, and like Dr. McDonald was saying, it's not just meeting the requirements, but the painful ongoing upkeep of everything that you're supposed to be doing. So that's a big factor. The other thing that I think is maybe somewhat better within Kaiser is the chronic disease management, because what we see on the endovascular side of things is the end result of not doing things properly on the front end. So although we're okay at blood pressure management, hemoglobin, A1C levels, cholesterol levels, and so on, there's always room for improvement. But I think overall, we do okay there. So historically, that's what we've done. On the acute stroke side, if you cannot prevent things, and on the acute stroke side, we've had a really quite a big change in the way that we triage and handle our stroke patients, starting about a year and a half ago. And so now there's a much more rapid process within the Kaiser system of assessing patients and determining what the best course of action is. And so it's a teleneurology network, a PACS imaging network that's really been, I hate to use the term game changer, but it really has been a game changer. That kind of happened in sequence with the major endovascular trials that were published in 2015. And so those 2 things together really changed things as far as my ability to sleep at night, because we're treating a lot more patients endovascularly now, but we're also treating a lot more people with IVTPA in a rapid time window. So that's what we've been doing. What I would like to see happen in the future is a few things. One is, I think, just continuing to improve upon the protocols that we have for our acute stroke patients. and bring down the time to treatment. The other thing is, these studies, like the Dawn trial, will certainly